Okay, good afternoon, everyone. You're very welcome to today's CPD webinar here at the Discipline of Radiation Therapy at Trinity College Dublin. My name is Michelle Leach and I am Professor in Radiation Therapy, and I will be moderating today's webinar. So I'm delighted today to be joined by Professor Sara Faithfull. And Professor Faithfull is an adjunct professor here in our discipline in Trinity College. And her role is to support PhD supervision, teaching and research in relation to cancer treatment late effects, survivorship and supportive care, which she's speaking to today. She trained as a cancer nurse in 1986 at the Royal Marsden Hospital in the UK, and she worked within oncology and radiotherapy, urology and nurse education. She was the recipient of the Smith and Nephew Nursing Fellowship in 1991 and received a Cancer Research UK Nursing Research Fellowship in 1994 for research on supportive care and radiotherapy. And she's recently retired from the University of Surrey as a clinical academic in nursing and research impact champion for health sciences. She was also a board member of EONS, which is the European Oncology Nursing Society, and was its president from 2008 to 10. And she is currently a nominated member of the European Academy of Cancer Scientists and has authored more than 100 publications in peer-reviewed journals. She has fulfilled many roles over her clinical academic career, supporting research development within the Living with and Beyond Cancer portfolio for the National Cancer Research Institute in the UK, as well as medical advisor for the Pelvic Radiation Disease Association. And I could go on and on, Sarah, but I think I'll probably stop there, stop cutting into our time. So I think everyone will agree that you're extremely well placed to deliver this presentation to us today, and we're delighted to have you here. And as you're just about to share your screen there, I'll just ask the participants if they have any questions for you over the course of the presentation to use the Q&A function, please. And we'll have a conversation at the end about your presentation. So that's great. I'm going to stop talking now, Sarah, and hand over to you, and I can see your slides. So I think all is well.
Thank you. Thank you for the invitation. And yes, I'm very old.
No, not at all.
Really today, what I wanted to do in this talk is do a bit of a sort of whirlwind sort of tour in a sense of some of the challenges in long-term and late effects management, and think about also how we can, during treatment, actually sort of improve how we support people who live with and beyond cancer diagnosis. So I want to sort of describe initially the emergence of the survivorship models, think about the sort of policy shift, think about prevalence of long-term and late effects, and then sort of really explore how the symptoms appear and the sort of clustering of symptoms, and how we can use symptom science to think about how we guide future research, but also how we can use this sort of approach for interventions. And then really sort of think about, can we use more risk prediction models in late effects? Because a lot of the late effects you need to be treating early, maybe during treatment or changing therapy, and then how we might stratify that in survivorship care. So it's quite an encompassing talk, but I really want to sort of give some key messages, but also think about how we might develop some of these areas as we go forward. So the significance of survivorship is that it's, cancer now is a fairly good news story in that the number of cancer survivors is growing. And, across Europe, the 10-year survival is good. And we have about 20 million people in Europe who have had a cancer diagnosis. And in the UK, it's about 4% of the population will have had a cancer diagnosis, which is quite substantive. When you're looking at primary care, you're seeing 1 in 14 older people who would have been treated with cancer in their early life. So what we do know is that survivors have poorer physical and psychological health than the general population, but they're more likely to have second future cancers. So we need to think about their long-term care, identify those that are at higher risk, but also think about how do we do the care for cancer patients as the numbers of these patients are increasing. So if we're sort of struggling with actually treating people at the moment, and I know in Ireland this is an issue in terms of waiting lists and care provision, It's the same in the UK. We've then got all these people who are surviving and needing follow-up and support. How do we put models together to actually provide that support? So if you're interested in this area, there's some papers on the right-hand side that really talk about the issues of survivorship more globally, but also thinking about what are the challenges for providing these survivorship models. So the policy initiatives really started in the 80s and it came from sort of the US, very much from cancer patient to cancer survivor, this lost in transition, which was about 86 to 90, where the Institute of Medicine really drove the survivorship agenda. In the UK, in the early 2000s, we were looking at the National Cancer Survivorship Initiative and developed this sort of adult survivorship concept, very much based on the US model, but then also that have developed that into more of a long-term conditions model. Then in Ireland, you've got the Unmet Needs of Cancer Survivors and the Irish Cancer Society 2019 Scoping Review, and then their policy and needs assessment about living with and beyond cancer. But from policy to implementation is a big step, and how you actually operationalize that at a clinical level for all patients is quite a challenge. And that's what I really want to talk about. So this is the Irish Acute Sector Survivorship Services model, which is very much about risk stratifying patients and looking at patient-centred individualised care. But risk stratification is often disease-focused around recurrence. It isn't about necessarily, are these people more likely to have late effects, for example, cardiac effects or metabolic effects, and then thinking about that risk stratification into a survivorship pathway. Now, this is the sort of model of care in Ireland that is suggested in terms of policy, but I don't know what the reality is and whether this is actually in place. And from my experience with talking to people is that it's not yet embedded in clinical care. And that, you know, do we know whether a survivorship clinic makes a difference and whether we are actually improving symptom control? So these are some of the things to think about. When we look at late effects, you know, how many patients get late effects and what are late effects? Well, late effects occur usually between 6 months to a year after treatment. And we often talk about the sort of acute effects, which are during treatment, where we're managing those usually at a therapy level. You know, things like skin problems, nausea, vomiting, you know, that's sort of what I'd call the bread and butter of oncology in terms of neutropenia, chemotherapy delivery, that sort of thing. But when we're talking about then long-term and late effects, long-term are those that go from acute into these late effects. Now, from radiotherapy, late effects can occur up to 5 years to 10 years post-treatment. And the sort of medium time point with radiotherapy is usually at the 2-year period. So you've got to really look well beyond the acute therapy to think about late effects. Now, what we know from population level studies is that survivors of a range of different cancers have much higher side effect profiles than people who have not been treated with cancer. And I've picked a few here from our overview paper where we looked at population studies. So, for example, patients who've had colorectal cancer treatment, post-adjuvant therapy are 7 times more likely to have acute kidney injury. It does improve over time, but in that long-term period are at high risk of renal problems. Then you've got non-Hodgkin's lymphoma and multiple myeloma, much higher incidence of cardiovascular disease and hypertension. And then neurocognitive effects occur in about 40% of cancer survivors, which is where you can't think or make decisions. And it's often related to endocrine therapies and also some of the chemotherapy agents. And it's often a key reason why people don't return back to work. We know that if you're a breast cancer survivor and have your nodes irradiated, you're more likely to have hypothyroidism. So these sort of issues in terms of fatigue, peripheral neuropathy, are key long-term side effects that affect quality of life and also people's functional ability to return to a normal life or return to the work that they did before they had cancer. And how do we know this? Well, there's some big population level studies based from the Netherlands, from the UK, but also from Norway, where they have good population level data. So if you look at the impact of late effects on healthcare utilisation and return to work, we know that breast cancer survivors who have arm lymphedema use 30% more healthcare services than comparators, and that it still occurs 10 years after cancer. We know that long-term survivors of cervical cancer are more likely to have a disability pension and not return to work, and this is often associated with late effects. We know that sick leave of people 12 months after they've been treated for colorectal cancer is 21% for just regional localized disease, 33% for regional, and 52% if they've had distant metastasis. So it's about the sort of scale of therapy that people have had and how that impacts. And, you know, breast cancer survivors, you know, have a high surveillance rate in terms of mammograms, but also have an increase in emergency care. So although we know that a lot of the what I'd call life-threatening or acute side effects are relatively rare after cancer treatments, for example, a lot of the cardiac toxicity is mitigated in fairly localized treatment. When you've got multi-modality therapies, endocrine therapies on top of that, then you're more likely to have longer-term health problems as people age. So it's complicated in the sense of not all cancer survivors get the same health problems, and that there is a key risk factor in relation to this. So one of the risk factors is if patients have comorbidities, then that puts them at a higher risk. So low risk patients are those that have single agent therapies, fewer therapies, and their late effects of cancer treatment are relatively rare. They may have fatigue, they may have some side effects after cancer treatment, urinary problems, all sorts of things, but they're fairly contained and have less of an impact on quality of life. Now, when you think about hypertension, when you're thinking about comorbidities, at the moment, patients coming into treatment, about 20% are hypertensive. This is in the UK. In America, because of obesity, it's about 40 to 50% of patients starting cancer therapy will be hypertensive. And this is a big risk factor for a lot of chemotherapy agents and also for mediastinal radiotherapy or any cardiac related drugs. So when we talk about moderate to high risk, prior hypertension is a big risk factor and puts people into a higher risk category. If you have anthracyclines, although we give lower doses now, some patients are more likely to go on, if you've got these pre-comorbidities, to have cardiac effects. And drugs like antimetabolites like 5-FU and capecitabine are almost as bad as the anthracyclines in terms of causing cardiac effects. Platinums cause peripheral neuropathy, as well as endocrine therapies causing metabolic problems. And the taxanes and newer therapies, such as VEGF, have a high incidence of cardiac toxicity. So patients who are having these therapies are what we'd call moderate to high risk. They may finish treatment with some side effects, but are likely to have long-term effects and late effects that will occur as they age. Now, I put a but here because we need to keep it in perspective. And I don't know if you can see the top of my slide. I say keep side effects in perspective. We have reduced chemotherapy doses across a lot of therapies. We also are much more aware of toxicities and treat them more. So actually, we are not seeing as many as we did, but actually some of the complexity of toxicities we most probably are missing, because when you look at patients' PROMs in terms of their patient-reported outcomes, things like fatigue can occur in about 40% of patients, and in Hodgkin's lymphoma, that fatigue can last at least 10 years. So the side effects can occur over a long time period, but may not be life-threatening, but can cause quality of life issues. We know from PROMs that we underreport in terms of things like toxicity rating. So if you look at clinical trials, most patients would fall into that low risk category. in terms of grade 2 toxicity. But if you look at PROMs, it pushes them more into the moderate and higher categories in terms of side effect profiles. So we've got to personalise and risk stratify survivorship care to actually think about these things. So it's complicated in terms of that risk stratification. I'm going to give you a little example of some of that complexity from a study I was involved with, where we looked at patient-reported outcomes and late effect symptom profiles and looked at the cluster of symptoms, because we collect lots and lots of data in terms of patient responses. When you begin to look at some of those responses, do we need to be collecting so much data? Are there key things that tie together that we can target that might actually make things better? And this is post-radiotherapy for prostate cancer. You can see here the acute side effects, the recovery. But one of the things that people really had difficulty with was this, which is urinary leakage. And with radiotherapy and prostate cancer, we rarely talk about urinary incontinence or problems post-treatment. But this is 2, 3, 4 years out. And this is to do with fibrosis and relating to urinary problems in terms of post-function. So when we looked at the symptom clusters and we logged and grouped the urinary symptoms together, rather than looking at the whole quality of life issues and a huge range of problems, there were some key things that patients found most problematic. And it was urinary leak, urinary control, dripping, feeling wet. And this was a cluster of symptoms that actually was more representative of the impact on quality of life. So what's the significance of this? Well, if we can identify symptoms over time that are really important, and what I've put here, it's what's important for the patient, is that we can then begin to look at risk prediction models. And can we pick up these patients at the treatment time point where we're collecting the symptom data? So, for example, if you look back at those patients in the clusters, they had a lot of acute symptoms during treatment. We could then predict that they're going on to have more future problems in terms of fibrosis and would need more monitoring of their urinary symptoms over time, and would most probably need stricter stretch or pelvic floor exercises and more management. So when we're thinking then about intervention, do we intervene earlier here in terms of that acute symptoms to be able to reduce those late toxicities? Now, at the moment, our model is very much about waiting until someone gets side effects. And, when we talk to patients, it's often, well, these symptoms are rare. We don't tell them then about what are the things in the future. And what happens here from my colleagues who do late effect services is that patients come very late, and that then the management of these problems is difficult to reverse. So we can use the symptom science model, which is a model for trying to look at the complexity of symptoms. And the way that really medically we often think about symptoms is that what I call symptom SWOT, which is basically we look at one symptom, treat it, look at the next symptom, treat it. And what we don't look at is the whole biobehavioral factors, whether there's phenotypes, are people at higher risk, and looking at things like social determinants of health. For example, we know that those people who have higher social inequalities are more likely to have late effects and side effects, because often they have hypertension, may have metabolic issues, maybe prior to coming into treatment, or that they don't have the abilities to actually come back into healthcare early, may have been, missed appointments, those sorts of things. So this model is quite useful to begin to think about symptoms. And if you're doing research in this area or thinking about doing research, is to think about that complexity. And by looking at the population health data, which I showed you at the very beginning, it gives you targets and areas to try and identify people at higher risk. So what's the key message from this, really, in terms of symptom clusters? Well, the first is we need to actively assess symptoms throughout the treatment, and that your work during the therapy is critical in terms of picking up people who are most probably going to have problems through their long-term survivorship. Also, in terms of identifying those most at risk, of late effects through early symptom recognition and patient-reported outcomes. So try to actually follow people up to be able to look at their side effects, but not just through grade 2 toxicity or CTC, but through what patients say their symptoms are, because we know there's a discordance between clinician rating and patient rating. But also we need to review the pure management strategies and think about clusters and about what are the things we should really target, but also think about crossover between symptoms. So, for example, we know there's a link between fatigue and cognitive dysfunction after chemotherapy. Now, Michelle, I see that there's a question on the chat. Is it something that I should answer now or at the end?
No, I think we can hold it to the end, Sarah, if that's okay.
Rightio, I will come back to that. So I'm going on to my next area, which is really that one of the key things which is in the policy statement is about rehabilitation. But part of that is that we need to do prehabilitation. So we know that more patients are coming through with hypertension, metabolic issues, and that people are more obese now. So we need to be thinking about how can we improve people's health before they start therapy. And this is quite important because, like with radiotherapy, we know that if patients have good oxygenation, that they're going to do better from the radiotherapy, but also in terms of recovery. So when you look at the prehabilitation, we know that giving people exercises and improving their nutrition before therapy improves their acute recovery, but also if you give them rehabilitation afterwards, then they will do better than other patients over time. And it is a critical zone in terms of something that we may not be focusing on, which is actually improving symptom management through rehabilitation, thinking about return to work, enhanced recovery, those sorts of things. And there's some good papers I've quoted below in terms of good overviews in terms of rehabilitation. Now, how can we, well, you sort of say, well, we do have a rehabilitation program or an exercise program, but we would flood our services if we sent everyone to rehabilitation. But there's things that we can do as clinicians that can make a difference. And it's thinking about that health prior to treatment, getting people's tension treated and managed, thinking about well-being before therapy when you may be simulating patients, or thinking about that sort of pre-treatment, picking up people who are maybe higher risk. So I'm going to give you an example. This is a radiotherapy intervention. And it's a multidisciplinary rehabilitation of patients who have pelvic radiotherapy for prostate cancer and who have lower urinary tract symptoms. Now, there is high quality evidence of the benefits of rehabilitation on reducing urinary symptoms after surgery, but also after radiotherapy. And what I'm going to say is the intensity and delivery of that is really important. So what do I mean by that? Well, if you look at, when you're doing radiotherapy, I'm going to teach you to suck eggs here, most probably, the pelvic floor musculature, but when you think about the pelvic floor here, it's like a hammock. So if you think about a hammock with all the muscles, these are treated with radiotherapy. And what we know is that urinary symptoms are common after radiotherapy to the pelvis, and they impact on patients' quality of life. But what you may not be aware is that the pelvic floor muscles actually decline after radiotherapy, and that can be an impact on the pelvic floor in terms of the urethra and the sphincters, in terms of control of bowel and urinary. So a study was done called RePCA in Denmark by Karen Dippernick, and they did a multidisciplinary rehabilitation intervention. What they did was a randomized trial. They did pelvic floor muscle exercises, counseling, and a one-to-one approach with a psychologist and a physio. And they used this intervention to look at symptoms during and after radiotherapy. And they provided this intervention for everyone going through pelvic radiotherapy. And what they found was there was a significant improvement in men's urinary hormonal symptoms and physical quality of life at 20 weeks. Now, they did a further study which they actually looked at 3 years post-treatment. And that intervention continued its benefits. So those pelvic floor exercises continued to improve people's symptoms. And there was a big difference between, even at 3 years, between those who had no intervention and those who were given pelvic floor muscle exercises and counselling as part of side effect management. Now, we had done the pilot study for that study, and it took so long for me to get funding that by the time I got the randomized trial funded, Karen had actually published was doing her study. And in the UK, we're really short of money. I'm sure most healthcare providers are. But we couldn't afford to do one-to-one. And what we did was we targeted only those patients who went on after they had radiotherapy to still have acute symptoms. So we monitored people with the symptom cluster model and picked out those who had acute symptoms and went on to continue to have acute symptoms with the IPSS. So anyone who had a symptom above 8. And then what we did was they went over to the leisure centre, which has good parking and, you know, all those sort of things. And we did a lifestyle class with sort of exercises for pelvic floor muscles. And we did bladder retraining, pelvic floor muscle exercises, very similar to Karen. But we provided some of it in a group session and some of it in a one-to-one. And the sort of rationale for that was that the peer group would help, and we found a significant improvement, a bit like Karen, in men's urinary symptoms and coping, and we found that at 3 months there was a difference, but the benefit was not sustained, not like the study in Denmark. What was the difference? What was the issue? Well, we didn't do one-to-one. And what you found when you were doing the sort of assessments in patients is they had very different side effect profiles. And some people found pelvic floor exercises difficult to do. You couldn't physically examine people in a class in a leisure centre. And you couldn't really then do biofeedback or check out what their pelvic muscles were doing. But also we started after treatment, not during treatment. And that made a big difference in terms of the ability for people to regain control over their pelvic floor. Before, we were doing it after radiotherapy rather than following that prehabilitation, rehabilitation approach. So it did have an effect. The self-management was valuable. It helped patients in terms of their pelvic floor exercises. It was quite cheap to do, but it did not have the efficacy of the study above. So my key messages from this in terms of interventions is that what we tend to do is we look at the research when we're coming up with clinical interventions, and what we do is we pick what we think we can deliver from that intervention that's maybe complex. And complex interventions by their nature are complex, and they have interactions between. So a bit like the symptom clusters, what we found was that you need some of that psychological, the counselling, we need the support, the behavioural change, the exercises, you know, the information on drugs and all of that. It was complex. If you cherry pick, change the intervention structure, change the timing or delivery, it can impact on the efficacy of the intervention. And what we found is contextual factors are important in the outcomes in relation to the population. So, for example, we were using patients who were already at high risk, not the general population, and so we were taking people too late. Also, you've got to balance the cost effectiveness. So we had to ask ourselves, if you put this intervention in place, would what we've done be enough to make a difference? And the patients who went on to have more long-term effects, would it have actually changed their outcomes? Well, most probably not. Sorry, my earpiece has just fallen out. So you've got to balance what you can afford, but also you can't always expect to have the same quality of intervention effect. And self-management is really valuable. And I always describe it to patients as self-management is the bread of a sandwich, you know, like this. What is important is what goes in the middle. And if the middle bit is not necessarily tested or is not effective, then the self-management has very little impact on patients. I see Maeve has raised her hand. Do you want me to take this question now, Michelle?
No, if it's okay, Maeve, if you can hold off till the end, we'll do that, if that's okay. It must be something burning, so.
Yeah, it's mostly to do with self-management. So
Yeah.
self-management is really valuable because what it did give is the patients the ability to cope. So what it did is it gave patients the ability that they felt they could do something themselves to make a difference. But if the meat in the filling of the sandwich is not sufficient, then it most probably is not going to change their symptom profile. And so you've got to have the evidence for the intervention to go in that self-management provision. So it's a delivery technique. And I think what happens is that we think that it's all encompassing and a bit of a panacea. So just bear that in mind. We'll come back to that at the end. So I'm going on to another symptom, one which is very common, chemotherapy-induced peripheral neuropathy. You obviously, with radiotherapy, you may not be seeing it, but patients may have it from their prior treatment, especially if you're doing radiotherapy at the end of their chemotherapy regime. And it's a really devastating consequence of neurotoxic chemotherapy agents. And what we know is that about 20 to 80% of patients on neurotoxic chemotherapy will get it. And roughly it's highest in the first month after completion, 68% of patients. So you may be seeing patients who've got it, and 30% go on to have long-term irreversible damage. And it's usually in the feet and hands, and in terms of the manifestation of the symptoms, but it causes gait problems, balance issues, it's painful, you get cold, when it's cold, it's more painful. And the guidelines in terms of how you manage it is that you have to pick it up in the acute stage of the delivery of the chemotherapy and change the dose of the chemotherapy or the delivery in terms of the relative dose intensity. So reducing how quickly you give the chemotherapy, either having gaps, that sort of thing. And we know that it can impact on efficacy of treatment. So an audit we did in the UK where I was working, we found that only 65% of patients who had neurotoxic chemotherapy completed their chemotherapy regime in totality for their kilograms per meter squared, because they had dose reductions or didn't have the final course of therapy. And for some cancers, fast-growing cancers, it can impact on cancer survival and outcomes. What we know from the guidance and the ASCO guidance, and there's also ESMO EANO guidance on it, there are no level 1 recommendations. So what does that mean? Is that none of the research that has been done in terms of drugs, intervention, things, has enough quality to say, yeah, this is what you should use. And what the guidance is that you need to talk to patients about it. If they're doing a job with their fingers, it's really important to make those decisions before they start their chemotherapy, because you may be able to change agents or alter the peripheral neuropathy severity by altering the relative dose intensity. Now, in my experience as an oncology nurse, is that this rarely happens, and that we very rarely ask patients about what sort of work they're doing, how important their fingers are, are they using they have to balance in their work. And this is why a lot of patients don't go back to the work they were in before, because they may not be able to do it. So just to understand it, all right, and I'm going to show you a bit of the pathophysiology, but when you look at how the different chemotherapies work, if you look at the taxanes, vinca alkalides, they affect the nerve terminals. So in your little fingerprints, you've got these nerve terminals, and they retract with the chemotherapy and they get damaged. But the majority of chemotherapy, like the vinca alkalides, the taxanes, affect the microtubules, which are much further away, can be in the spinal cord. So you've got a lot of, like the platinum compounds, a lot of the drugs have multiple targets in terms of the pathophysiology. And they don't affect necessarily the hands or the feet. They affect the nerves to the hands and to the feet. And I'm stressing that because I'm just going to show you about the sort of interventions. Now, what we know is that there are markers that we can pick up, biomarkers for the different drugs. And what we think will be a future target in terms of biomarker is what's called a neurofilament light chain, which is to do with damage to the myelin sheath and called the axonal damage that you see in the cells. And there's a lot of talk about, is this something that we could do as a blood test to pick up people who have got higher risk? Now, when you're in clinic, when the guidance says in the ASCO, in the CTC AE, is that grade 2 toxicity, which is where you should dose reduce or stop, is that they've got an EEG. Can a patient do up their buttons or not do up their buttons? And what you see is that that's used as an assessment marker. There is no neurological assessment really of the neurology. And so patients' treatment is often changed through really, really basic assessment techniques in terms of asking a patient whether they can do up their buttons or not do up their buttons. And so we think in the future there will be a biomarker. It's already available for Alzheimer's and is being marketed, that in the future we may have a biomarker that we can use during therapy to say this patient's peripheral neuropathy is getting worse. But will we change anything? And this is a question we ask in clinical practice. Because when you do qualitative research, what we find is that for patients, they don't tell the clinician that they've got peripheral neuropathy because they're, one, frightened that someone will stop treatment, but also there's a lack of awareness of that the peripheral neuropathy is a big problem, that if you don't deal with it during treatment, it will have a long-term effect. We don't talk about it and there's very little information. But also that it's a very hidden side effect of chemotherapy in that it's not treated like nausea, vomiting or neutropenia, which we focus on. From a clinician's perspective, this is interviewing oncologists and nurses, it's seen as relatively insignificant. But from a patient point of view, it's very distressing and overwhelming. But the focus is on the acute symptoms, not the long term. Very few neurological assessments are done in oncology. And there's a dependence on the patient reporting. So if patients are thinking, well, if I tell the doctor and they'll stop my treatment, then they're not going to report their side effects. And so it's really challenging in terms of how you might use these things. And this is where a biomarker might be more valuable than asking patients about their side effects. It's something that you can look at. However, when we talk to clinicians about, if you have a biomarker, would you bring it? Would you use it in practice? All this sort of thing. How would you change it? Would it? And they said they would not use it because unless you have an intervention for peripheral neuropathy, there's no point. There's nothing you can do. Now, this study is a study on over 3,000 patients that my colleague and I did, looking at the SCOT, which is colorectal cancer patients, and we looked at chemotherapy regimes. And we looked at patient-reported outcomes. And what we found was that the peripheral neuropathy prior to people starting treatment, so here's the baseline, and these are the people on the different chemotherapy regimes, the different colours. Oh dear, sorry, it's very sensitive mouse. But what you find is that if you have no peripheral neuropathy at baseline, you're unlikely here, you see, to go on and get any long-term effects at 6 years. If you have any peripheral neuropathy on a score of a 4-point scale, at that point, at a baseline, you are likely to go on. And what we know is 20% of the population are at higher risk. So there's assessments we could do pre-treatment, and we can then, when we were looking at the chemotherapy dosing, there's a big difference between the CAPOX and the FOLFOX regimes. Same dosage. This is a study about dose reduction. But the relative dose intensity of the two drugs is given differently between CAPOX and FOLFOX, because the capecitabine is oral and the FOLFOX is an IV. So you get very different drug intensities in terms of absorption, and it has a big impact on peripheral neuropathy. So there's things we can do, and we can actually look at that drug, the pharmacodynamics in a sense of how people absorb their drugs. And we found that age, sex, and BMI made no difference because of the large scale of the study we did. But what I would say is interventions, there's no evidence of efficacy at the moment. Neuroprotective agents, they've all proved ineffective. There's been over 70 studies. What they say is treat painful peripheral neuropathy with duloxetine. Doesn't work very well. Okay. Acupuncture gives short-term relief, but you need to do maintenance for the longer-term symptoms. And exercise improves function, balance, and strength, and is the only intervention that actually has positive results. And the current recommendation is reduced dose during treatment. Okay, so this is the evidence. This is what the guidelines say. What do people do in practice? Well, this is the evidence for exercise, and I'm showing you this is a meta-analysis. If you do exercise with peripheral neuropathy, you get better balance control, upper body muscular strength, and lower muscular strength. It's positive on all counts. But we don't do rehabilitation for peripheral neuropathy particularly, and it's not in the guidance as being something that we would recommend all the time. But this is the only intervention at the moment that shows a benefit outcome. Acupuncture shows benefit in reducing symptoms. They do not reduce your peripheral neuropathy. They reduce your function. They improve your function. So this is a study done by Bejes in Netherlands. Big study, largest study, looking at cold gloves, frozen gloves you put on a bit like your hair cap for chemotherapy to reduce peripheral neuropathy. Really good study, very good randomized trial. There was no significant difference in peripheral neuropathy scales between the intervention and control arms, and a third of the intervention group discontinued the use of the frozen gloves. And I will put that out there. Brilliant study, very well controlled, really clear. What do we see? Right, this is an international study done last year. 29% of cancer centres are using cryotherapy gloves and feet socks for patients who are on chemotherapy. 40% use gabapentin, doesn't work, it's not in the guidelines, and 49% use vitamin B complex to improve peripheral neuropathy, doesn't work. All the studies show it has no effect. And this was presented at Mask in June. But what you see, I've just picked a few pictures from the internet, is that you can't commoditize exercise, but you can a glove. You can buy it. You can, it fits in with your cold machine for your caps. And the drug companies, these companies provide evidence based on usually descriptive studies that do not include those people who drop out. And if I go back to the study above, a third of the intervention group discontinued use of frozen gloves. If you don't include those people who drop out, it affects your results. But also, it doesn't follow the science. The science is that it's in your spine, it's in the axons, it's not in your fingertips, it's only a tiny bit in your fingertips. And what they say is patients feel it makes them better. So, coming to my final slide. The important challenges is that we need to focus on patient-reported outcomes because we'll see more side effects and comorbidity outcomes. We need good quality data at scale to look at these long-term health if we're going to predict and risk stratify patients. We need to use AI and machine learning to look at these sort of data sets because it's complicated. You can't easily risk stratify without looking at that. And we need the clinical data to inform risk prediction. And what we're seeing is a change over time in terms of those comorbidities that needs to be built in. We need to match interventions to patients. We need to use predictive risks to actually focus our interventions. And we need biomarkers to sort of really look at side effects much more accurately and in more precision than we do at the moment. We need interdisciplinary research. Most of the studies are single centres. We need to build this research capacity around late effects. And we do have promising interventions. Look at the exercise and rehabilitation, lots of evidence. But there's less clarity because we can't provide it for everyone on which patients to apply it to. And we need good examples of self-management, digital health and rehabilitation that really can be rolled out and implemented into a broader health system. So survivorship needs to be much more personalised and risk stratified. That's my final slide. And I just want to thank my colleagues who've worked with me on my research, and also to the previous National Cancer Research Institute later consequences research group who helped with many of these studies. So thank you. I'm going to stop sharing and go back to Michelle.
Thanks very much, Sarah. That was extremely informative, and I've been jotting down loads of questions here while you were speaking, because I just find it so very thought-provoking for those of us who are, involved in treating patients on a daily basis, and not, sometimes necessarily thinking all the way through to 4 or 5 years later, But I will go, before I start with a question of my own, I'll just go to the Q&A. I think probably some of your slides have answered this, because I think it was put in early in the talk. If you track the symptoms in the acute phase, is there evidence to demonstrate that earlier intervention would reduce those late side effects rather than wait until presentation? So I think you've kind of given...
That's a really good question, because it depends. So, for example, with lower urinary tract symptoms, I would say that it depends what type of symptom people have got. So, like whether it's a voiding symptom or a storage symptom. With, like we know, with gastrointestinal pelvic problems, the acute symptoms actually predict those people going on to have long-term problems. And they think it relates with the radiotherapy to the microbiota and how the gut is affected with the radiotherapy. So there's a new guideline about to come out, and when it's published, I'll put it with the send it to Michelle, but it's coming out from the sort of surgeons on colorectal sort of disease, in relation to how best to manage some of these side effects. But what they say is manage it acutely, and then you're less likely to go on to have long-term side effects.
Yeah, I think there's quite a lot of evidence of that for late xerostomia, isn't there, in head and neck cancer?
Yes, but I think also that if you're thinking about post-radiotherapy, then if you've still got a lot of side effects at 1 month, then you're going on to have chronic problems.
Yeah. Okay, thanks for that. And then the other question, other questions in the chat. Do you see a difference between males and females in the efficacy of rehabilitation? Well, that's quite interesting.
Oh, that's a good question. It's funny, on Monday we're talking about it in terms of cardiac oncology rehab, and that men go to it but women don't. And what I find is, I work mainly in prostate and pelvic treatments, that men don't like going to a mixed class, and that you rather than go if it's specifically around symptoms, they're more likely to come because it's an intervention that they can do something themselves to make a difference. And so you can add in all the little psychological bits, like around sexual function and things that are embarrassing and stuff like that, and do a more broader approach, but that it's sort of like targeting people to bring them in. Whereas I think with women, the peer group is much more important. Whereas I think with the men, it's not so, it's different.
And what about, though, in terms of kind of biology between males and females? Does rehabilitation work better in one or the other, or do we know that?
It depends on your disease. So, for example, women are more likely to get cystitis, which is more inflammatory. So it's not so much that, like, the pelvic floor is just as important in women. And, so it sort of depends where the treatment is and the organs that are affected. But it's also, again, the risk factors are the same, which is hypertension. And, it's all to do with vasculature, which, as from a radiotherapy point of view, is really critical. So, if you've got hypertension, prior heart disease, then you're more likely to go on and get fibrosis and strictures and problems. Whereas, like with younger women coming in with gynecological treatments, it's the multiple therapies impacting in terms of things like radiation cystitis and stuff like that.
Okay, thank you. And the last one in the Q&A is, are we any closer to late effects interventions becoming standard practice as part of primary treatment pathway, or is it still very much case-by-case basis?
Well, I think I've spent my whole career fighting for late effect services, because if you think back to that key message, which is keep it in perspective, majority of patients don't go on to have severe late effects. You know, they may have fatigue, they may have some, you know, changes in diet and all, you know, those sort of things. But and so if you're looking at a service that is like localized, then you won't have enough patients to run a clinic. And you know, we do business cases in the UK for any change in service, so you've got to actually work out the cost benefits of providing care, and it's quite useful to do that, because what you realize is actually you've got to do it from a regional level. You also, as an individual, can't treat everybody because of the different specialities you need. So, for example, if I was running a late effects service in prostate cancer, I need a urologist I can refer people to who deals with strictures. I need most probably a physio for someone who's got more continence issues, maybe a psychosexual counsellor, you know. So you need almost like a network, like a web of people, you know, who specialise, like, for example, gut, that sort of thing. And how we look at late effects is that you're a navigator, you assess people. For the majority, you can give them basic information that helps them and some key stops and, you know, assess and all that. And then there's a group of people you would refer on to deal with the problem of most warranty. So, for example, I would normally get patients to draw bubbles of, you know, what's the things they've got, and then, okay, which is the biggest bubble that is more problematic? We deal with that one first, because they come with clusters of symptoms. And so you've got to actually think about what is the most important thing to focus on. So, yeah, we have here most probably 60 late effects services in the UK, run by therapy radiographers, because the commissioning here is that whoever gives the treatment has to deal with the late effects. And so therapists are taking the lead on this as advanced practitioners. But it's challenging because you can't, you know, if you can't specialise in everything. So some are doing head and neck, some are doing pelvic. And so if you have someone who's particularly focused in an area, you're looking at where the delivery of the treatment is. You know, so what's the biggest need?
Yeah. Okay.
That makes sense.
It makes lots of sense. It makes lots of sense. Absolutely. And I suppose we're a little bit envious of the number of late effects clinics that you're talking about.
The thing
there,
is
because
that in a sense, with Dublin being a core centre and St Luke's being, you know, so important in terms of, you know, you would expect there to be a late effects service there with cardiology, cardiac oncology, and you have cardiac oncology down in Cork. But, you know, it's like, okay, who's doing the gastrointestinal stuff? Who's got the interest? And it's partly through like the charity Pelvic Radiation Disease Association have pulled people together, and we wrote a best practice guidance, and by doing that found people who had an interest. So we now have like a network of people we can tertiary refer people to. But the thing is some of the really bad late effects are rare, and so you're not going to set up a whole service of like 2 or 3 people a year. So the majority you can deal with at a local level with self-management and support and things like that, and giving them the skills to actually sort it out themselves. But you do need the rehabilitation services and things like the, you know, metabolic health or diabetes and the link to primary care to be able to get people sort of managed well.
Yeah, I was just watching the time, but I have time for one question out of my list.
Okay.
Can I end on a philosophical one? There you go. Just as you were speaking, and what I was thinking about from our perspective in radiation therapy is about, you know, shared decision making, even informed consent of patients. And we know that when a patient comes to clinic for the first time, you know, it's a very overwhelming experience, given, you know, they're probably relatively recently diagnosed. And of course, you know, patients will always tell us that they don't take in a lot of information, or they want information in chunks, which is fine. But I'm just wondering, in terms of, you know, how much is too much information about late effects during a kind of informed consent process? Because obviously, you know, there's as you say, a cost benefit, and I mean cost to the patient, benefit to the patient, not monetary, to consider. I just wonder what your opinion was around that, because I know that there's no right or wrong answer. I just wonder what your opinion was.
The Royal College of Radiographers we have set national consent forms for the different therapies, and on the front is the acute side effects, on the back is the long term, and patients never can remember what's on the long term, and what they may have discussed it, but I don't think people talk about it in terms of the person's life. They will just say, well, this is rare, you know, rather than, okay, I'm a needlework. I do needlework and my job is embroidery and tapestry. If I get peripheral neuropathy, that's my career gone, you know. We don't talk like that in terms of shared decision making, in terms of do we change the therapy or that sort of thing. But also, when you're coming near to the end of treatment, it's a really good time to reassess patients, talk about the potential of later effects. And I would say to people, these may happen, but they're rare, you know, but be aware of it. Because what patients do is they'll go on and have, say, like their hemorrhoids done and not tell the doctor they've had radiotherapy. And then you end up with, like, you know, holes and all sorts. So it's the sort of thing that I think we should inform patients, but you don't need to give all the detail at the beginning, and then, you know, drip feed it so that people can then come back. And, you know, part of survivorship is about having open access back, and how we do that is quite difficult, I think, for patients.
Brilliant. Look, thank you so much, Sarah. Our time has run away with us.
But I love talking on my pet topic.
Well, it was very enjoyable and most informative. So thank you very much for joining us today.
Pleasure.
And thanks to the audience for joining us as well, whether that's at home or live here today. And just to let you know that our next webinar will be obviously next month in December, and we're going a somewhat related, I suppose, area, which is talking about setting up advanced practice radiation therapy, and we'll be joined by Nicole Harnett from Princess Margaret in Toronto for that one. So for so we bring up late effects as an APRT role for sure. But thanks very much, Sarah, and good afternoon to everyone. Bye bye.